patient is a 52-year-old journalist who has a clear medical history. She has a busy schedule but has been a regular attender of my practice 2 years ago. Her chief concern included the upper sensitive anterior teeth, which are sensitive to cold and sweets, general discomfort on the crowns done by another dentist 3 to 4 years ago, and thus has switched to this practice. Around the crowns there was an occasional bleeding on the gums and strange foul metallic taste from upper crowns after dental treatment. The patient also expressed a concern that the color of her front teeth are not uniform, and the patient is moderately dentally anxious. On examination, the patient has a fair occlusal stability with rotated and crowded teeth in the lower anteriors, making cleaning challenging. Initially, she had poor to fair oral hygiene, where there was a history of poor periodontal health with bleeding on probing and periodontal pockets exceeding 3 mm in posterior teeth, where basic periodontal examination score was 3, in which after that 2 years of supportive periodontal therapy and oral hygiene instruction is now 1. The 1-1 and 2-2 are crowned and splintered together as a bridge, and this was done by another dentist 3 years ago, but according to the patient, it did not reveal the details and justification of restoring 1-1 and 2-1 and splinting them together. The 2-1's endodontic status is questionable. It was non-vital, and calcium hydroxide and leather mix dressing were placed in its attempt to treat it. But later the 2-1 did not respond well to the treatment, and later was revealed that subgingival vertical root fracture was present all along. The diagnosis pertaining to this case would include vertical root fracture of the 2-1, marginal leakage of splintered crowns 1-1 and 2-2, where the crowns apparently were splintered to stabilize the 1-1 that was already problematic. Due to poor periodontal health, that time the patient was not aware of flossing and had chronic gingivitis. Treatment options were discussed with the patients and is all laid out in the clinical write-up. The definitive comprehensive treatment plan, well, the provisional treatment plan in the beginning was actually used as the case for 2 upper anterior crowns, in which after finding out that the vertical root fracture was imminent, it included an immediate implantation. So therefore, first we remove the disease. Supportive periodontal therapy has been used to stabilize, and sectioning of defective crowns and caries control, where the hopeless 2-1 root was eventually extracted. The patient is moderately dentally anxious, and during that process of anesthesia, we took the opportunity to implant the socket of the 2-1 so that both surgical stages were all made into one. The socket was curated for granulation tissue, and after implantation, the provisionals were placed. Take-home whitening tray was fabricated to spot whiten discolored teeth, namely the lateral incisors and canines, during the 3-month healing period. During the second stage, the uncovery of the osseointegrated implants, proper crown reduction was performed on the 1-1, where reduction was minimal but mostly redefinition of deep chamfer margins were made, with an appropriate index putty as a guide. Instead of a sulcus former, the 2-1 implant uses a temporary abutment, and both crowns are provisionals and have been individualized. They were left around 3 weeks for soft tissue adaptation until the impression stage. At the impression stage, the region is anesthetized again and an automatic crown remover is used to remove the provisionals. The natural 1-1 abutment uses a double retraction cord technique, and the 2-1 uses an open tray impression post technique. Heavy body and light body addition silicones were used as the impression material on the prepared special tray. Take note that the third purple impression material is actually an extra light body A-silicon expressed by the dental assistant by mistake. Provisionals were then cemented and screwed back to protect vital pulp and prevent collapse of soft tissues, and the shade has been taken. The patient has been advised not to use the whitening tray 2 weeks prior to shade taking. A lab form with the necessary descriptions has been sent alongside the impressions, study models, and bite records to the technician to have the crowns made. The finished case is then issued to the patient, where the abutment tooth is washed and cleaned with 2% chlorhexidine and pumice slurry to remove residual temporary cement and improve bond strength of the resin cement, as the abutment tooth will be cemented with an Emax crown with its coping silanated. The implant abutment is screwed and torqued with a red pattern resin index via a tapered connection, and a zirconia core full ceramic crown cemented with temporary cement. Patient is generally quite happy with the outcome, however there is a slight dehiscence on the labial surface of the 2-1 observed. A staged approach in implant therapy would give a much more predictable outcome, however the patient's anxiety level prefers shorter single-staged treatments. The periodontal hygiene needs a constant motivation to keep it clean, and there has been satisfactory stability after 1 year from the time of documentation.